You have any clinic today, or?
Yeah, no, a couple in the morning and one this morning. Nice to get a break. BBC doing general.
Okay. I'm doing cases all day with John. Just did an AST and then I just got out and come here and
specifically like structural? Or?
Yeah, just probably and
are you on the like roster for
yeah, just the way it works is like for the first year, I don't get much code.
It's interesting.
I mean, of course, I'm just diagnostic, but it's something similar with
now we don't have to say
for the first 6 months.
Once you have achieved those skills that you're missing, then
when did he stop?
So he's still practicing clinically, but he used to do the diagnostic stuff in the lab, and then he stopped end of 2013. He had a 6 month
And now you get one day a week?
Yeah, one day. Initially that was a lot, but now yeah, usually.
yeah, I agree. Just the interesting part was that if a person in this situation does,
I get also.
I see CTEPH all the time. We get a really sick transfer directed by for Android or she came in and she was essentially pre-shot. My kid works here, and she actually started to case, and you could see as I was injecting the coronaries, you could see that she the contrast was slowly moving down. So Richard came down to 60. But she's doing well and all.
Yeah.
She's still
that's
there.
they were going to be able to this week.
Recovering close to her. She may have to come back for
I mean, it's interesting timing. Because now
often they don't understand.
If you want to do some
There'd have to be a plan as to where they go. They may require an ICU.
But they're not sure how that now might change with this.
Yeah, there's plans to go.
Hard to find a program elsewhere when
I mean, I think we should meet with
having struggles with
whether Ken might be that person. And the thing is, James Raps isn't there.
WTF.
Yeah, maybe. I'll run if I can. Yeah, well, it's big enough. It's big.
good question. You did remind them that there's help.
Yeah. Stay in Toronto. Fly back.
And is your team coming?
Already did.
Okay, is your team coming?
I'm looking excited about that. Instead of the
Ongoing.
It was interesting. It's not a presentation that I read about. Super often.
It's an issue. It's nice to have.
Yeah. That's good.
I don't know where everybody is. Are you going to introduce?
Yeah, I had a few slides at the start.
Yeah,
and then
yeah, sure.
Yeah, fine. It's fine.
Sure. I'm just not sure.
Show there.
It's bad because they have the valves on the
They're coming, they're all on the way.
I guess I should use this one.
Where the hell are all the cardiologists? That's your excuse. And all be Catholic. It's not their fault. It's the interest.
It's pretty easy.
Yeah. Just wondering what's this microphone is there. Getting better at this. Are there other centers connected? I don't know.
Not sure.
Oh, I can see
You're
some.
beeping like it's kind of.
So who's going first? Nate?
I need
And then in UK it was so I hypertension.
this one, or you want to use this one?
Good morning, everybody. Welcome to Grand Rounds. This is the second Grand Rounds we've had here. The last Grand Rounds was at VGH. This is the second of the year at St. Paul's. I apologize to our speakers for the poor showing to date and hope that the rest of our teams will be in attendance. Today we have cardiology presenting, and Dr. Nathan Brunner, who's actually a graduate of the UBC program, both in internal medicine and cardiology, and who does outpatient cardiology at UBC, is in general cardiology, does pulmonary hypertension, is going to speak first, and he's going to introduce our next speaker. Nathan.
So it's great to be back and see some familiar faces. So I'm a general cardiologist out of VGH, and I do some work at UBC as well, and some diagnostic cath and cath for pulmonary hypertension about once a week over at VGH. But real star here is Dr. Riahi, one of our new hires, interventional cardiology, who did his cardiology training at Université de Montréal in Montréal, and also did some interventional training, structural training, congenital heart disease training in the UK as well, at St. Thomas. So I just have a few brief intro slides, and then Dr. Riahi is going to talk a bit about the interventional management of chronic thromboembolic pulmonary hypertension. Of course, an excellent topic, and I'm very excited for his talk. So just by way of introduction, so we're going to talk about discussing some of the pathophysiology and epidemiology of PH and of CTEPH, and I'll do that. We'll talk a bit about some of the clinical features and diagnosis. And then finally, Dr. Riahi is going to talk about the treatment, and that's going to make up the bulk of the talk. So chronic thromboembolic pulmonary hypertension, or CTEPH, as it's abbreviated, is the fourth group in the WHO classification scheme. And it's defined as the presence of precapillary pH on cardiac catheterization, so mean PA pressure of greater than 25, wedge pressure, which is our surrogate for left atrial pressure of less than 15, and a high resistance to flow through the pulmonary circulation. And there has to be the presence of chronic organized clot in the elastic pulmonary arteries. So if you biopsy the small pulmonary arteries in idiopathic PH, you can see in situ thrombosis, but you have to have chronic organized clot in the elastic pulmonary arteries, so anywhere from main all the way down to several subsegmental, and it has to have persisted despite adequate anticoagulation of at least 3 months duration. So following a acute PE, in the vast majority of the time, gas exchange and RV function return to normal, usually quite quickly, usually around less than a month. But in a minority, chronic thrombus can persist, and that can lead to development of chronic thromboembolic pulmonary hypertension. It's fairly rare. We're looking at incidences of around 4 to 6 cases per million. And depending on the population you look at, the series that you read, it develops in anywhere from 0.1 to 4% of patients who've survived acute PE. Now, a quarter of the patients in a large European PH registry had no prior history of PE, so it's something you need to think about in somebody coming in that you suspect has pulmonary hypertension, even if they haven't given you a history of thrombosis in the past. This is just a table showing some of the risk factors for going on to develop CTEPH after an acute PE. If you have recurrent PE, you're more likely to develop CTEPH. If you have a large defect on VQ scan, then your odds ratio is around 2 for developing CTEPH. If you have idiopathic PE, that's more likely to give you CTEPH as well. Also, the higher your PA pressures are on echo coming in, the more likely you are to have CTEPH. That being said, a lot of those patients probably had chronic CTEPH already and just were misdiagnosed as acute PE. Also, there are some hematologic risk factors for developing CTEPH, having elevated factor VIII, von Willebrand factor, having, interestingly, non-typo blood groups are associated with higher likelihood of having CTEPH, antiphospholipid antibody syndrome, and lupus anticoagulant positivity as well. And certainly, having malignancy increases your risk. Having had a splenectomy, having an infected device like an infected pacemaker, having a chronic inflammatory disorder. Interestingly, hypothyroidism is statistically associated with CTEPH as well. So this is just essentially a summary of different studies showing the incidence of CTEPH following a PE. If you look at all comers, it may be a bit tough to see there, but if you look at all comers following PE, the risk is around 1%. And if you look at people who have survived their acute PE event, it's usually around 2 to 3%. And if you look at survivors without major comorbidities, it's a little under 3% in terms of the average development of CTEPH, instances of CTEPH following acute PE. So CTEPH used to be thought of as a mechanical obstruction. So like if you were to put your finger over a hose, if you obstruct the pulmonary vascular bed, there's higher pressures in the part of the lung that's receiving blood flow. That being said, it's more than that. You can actually, if you biopsy the lungs of patients with CTEPH, you can actually get structural changes that are similar, in fact, identical to what you see in idiopathic pulmonary arterial hypertension. You can see plexiform lesions You can see intimal hyperplasia, medial thickening to the same degree that you see with idiopathic PAH. So essentially what happens is you get this mechanical obstruction, you get this chronic clot that blocks off part of your pulmonary vascular bed, but there are high shear stresses, there's higher flows and shear stresses in the open parts of the lungs, and that can trigger development of pulmonary vasculopathy, thickening, narrowing of the pulmonary arteries, like you get secondary to high flows in, say, a patient with a chronic left or right shunt in the setting of congenital heart disease. And that can trigger remodeling that leads to development of precapillary pulmonary hypertension. So that's why these patients do have been shown to respond to certain types of pulmonary vasodilator therapy. Dr. Onrod, you had a question?
Do you see those changes if you biopsy away from the areas that have been that have had emboli?
Exactly. So if you biopsy parts of the lungs which are not occluded, you'll see these structural changes as well. You don't often biopsy lungs with CTEPH, but in autopsy studies, these changes have been found. So in terms of diagnosis, so presentation, the history is often nonspecific. Patients will present with dyspnea on exertion, that's the most common symptom, or exercise intolerance. In advanced cases, presyncope can be seen. Syncope is a high-risk feature. On examination, depending on the patient's state, you may have signs of right heart failure. You may have signs of an afterloaded or right ventricle, such as the right side of S4. You may have an S3, murmurs of TR, and pulmonary insufficiency. In the European CTEPH registry, 75% had a prior history of PE. Just over half has had a prior history of DVT. And because of the non-specific presentation, the median time from diagnosis is just over a year, 14 months. This is taken from an article which describes a standard workup for CTEPH. So evaluating a patient with pulmonary hypertension, we start with a history and physical examination. We'll get some form of chest imaging. We'll get an echocardiogram as well. Our next step to work up high PA pressures is to do a VQ scan. That's our screening test of choice for CTEPH. And if the VQ scan is abnormal, then we're going to move on to do our CT to clarify clot burden and right heart cath to make the diagnosis of pulmonary hypertension. Conventional angiography only if it's warranted. We rarely will do an MRI, which is mentioned on this table as well, but we rarely do it. So this is a sort of a study which compared VQ with CT for ruling out CTEPH. It was a single center study, but fairly large as far as pH is concerned. 227 subjects compared VQ to CT with the gold standard being conventional pulmonary angiography. CT is more specific, but VQ is much more sensitive, and that's why that's the screening test of choice. And that's because of peripheral clot. The VQ scan is better for picking up peripheral clot than CT. Often it's missed on standard CT. But in reality, if we have an abnormal VQ, we'll get a CT scan as well. And these are features of chronic pulmonary emboli. So you can have features on CT. So you can have complete or partial vessel occlusion. These sort of things are seen with both acute or chronic PE. In terms of findings of chronic PE, irregularities or areas of wall thickening, recanalization of occluded vessels, calcified thrombus, bands or webs, mosaic attenuation, and evidence of pulmonary hypertension, so RV enlargement, RA enlargement, shift of the septum. So with that, I'll turn it over to Dr. Riahi, who will do the bulk of the talk, talking about treatment.
Thank you, Nathan. I want to thank Nathan for his support, and also when we talked about this idea of presenting about CTEPH, we thought, why are we choosing this topic? First, because we think it's an often unrecognized diagnosis, and probably the prevalence is higher than we think, and also it's highly treatable condition among the pulmonary hypertension subgroups. So I think it's important to raise the awareness about this pathology. So let's talk about treatment. There are three modalities of treatment. The gold standard would be the pulmonary endarterectomy, which is an open heart and also with the circulation arrest, and it's potentially curative. It's the gold standard with less than 5% in-hospital mortality, and however, less than 60% of patients with CTEPH are candidates for different reasons, they can be excluded from having endarterectomy. The second line of therapy, and it's more like an emerging field, is transcatheter balloon pulmonary angioplasty, which is an emerging therapy. First procedure was done in 1988, but the first series in 2002. But there's more and more experience with this procedure. However, there's limited long-term data, but we have enough evidence to support the use of this procedure because it improves the hemodynamics and also the short-term clinical outcome. And finally, there's the pharmacotherapy, and riociguat is the only approved medication for treatment of CTEPH thanks to some positive outcomes shown in a randomized trial. It shows that it improves hemodynamic and also exercise capacity. So let's talk about the pulmonary endarterectomy. It consists in basically opening the main pulmonary artery, get access to the pulmonary artery tree, and remove whatever clot can be found that is obstructing the pulmonary tree, but also doing a complete endarterectomy, meaning that clot can actually be fused to the intima and also the media, and often the surgeon will actually resect even the intima and the media of the some parts of the pulmonary artery, and that results that requires actually a midline sternotomy with a deep hypothermic circulation arrest. This is a picture of specimens. On the left side, we have the results of actually the endarterectomy. We can see that is fibrotic material, that is the fusion of the old thrombus with the actual intima of the vessel. And on the right side is only clot that was removed, probably secondary to an acute PE. So it's different procedures. And this is the first successful report of this procedure in 1973 in San Diego. And as you can see, it resulted in improved actually perfusion, perfusion scintigraphy pre and post. On this left, on the right lower lobe, you can see that there is better perfusion of this lobe pre and post. And following that, it became as I said, gold standard, and some centers became specialized in that with the highly expert surgeons. And this is the long-term outcome reported by the same center in San Diego after 1,500 patients. And so we can go through these patient characteristics. So the average age would be around 60. And the NYHA class, 12% had NYHA class 4, which is, and also the mean PA was 48. The PVR was 730, and most patients who have been candidate for surgery had even either involvement with the main PA or the lobal pulmonary artery tree. But the most patients who were not actually included or were excluded from having the surgery had more distal disease. And they had 3 years follow-up, median follow-up, and the survival at 3 years was 90% for the operated patient and only 70% for the non-operated patient. One of the strongest predictors of mortality was actually residual pulmonary hypertension. So you can see that patients who had a residual elevated PVR over 590 post-op did worse than the ones who had lower than that. And also predictors of mortality after the pulmonary endarterectomy is the age, dialysis-dependent renal failure pre-op, NYHA class 4, if patients were on a bridging therapy with the PAH drugs, if there is any cardiac intraoperative other operations, including valvular operations or bypass or anything like that, so it increases the risk, postoperative complications, and also residual postoperative pulmonary hypertension. But overall, the in-hospital mortality nowadays is around 4% in expert centers, and you can expect that mortality around 3 years should be lower than 10% in adequately selected patients. Now let's talk about the balloon pulmonary angioplasty. It's a transcatheter procedure. It aims at actually breaking those fibrotic material in order to reduce the resistance to flow, and we do that by using the usual coronary balloons, 2 millimeter to 4 millimeter balloons. So this is how it looks like actually from the inside. When you see an angioscopy, these lesions can look like webs or actually stenotic lesions, and this is fibrotic material. What you want to do is not actually to dilate the vessel, but you want to break this fibrotic tissue inside the vessel. This is the first reported BPA in the literature in 1988, and as you can see, this is the pre-op scan of ballooning of the right lower lobe. You can see the increase in perfusion in that lobe, and same thing here in this left lower lobe. There is an increase in perfusion as well in the same patient. And this is the first series. It's a Japanese series that was reported for 18 patients who were inoperable for PEA and had segmental lesions. They required 2.6 procedure per patient, but 11 patients had a reperfusion edema, which is a common complication following balloon angioplasty, and 1 death. They managed to reduce the mean PA pressure from 42 to 33, and here in these images you can see, see if I can scroll here. Okay, so you can cannulate the desired segmental artery. This is the balloon that is inflated, and you can see here the result, the fully expanded vessel with a good flow. And same report, they showed that the NYHA class improved, and also the 6-minute walk test improved significantly pre and post procedure. However, the rate of complications at that time in 2002 was quite elevated. We see that about 40% of patients had what we think was a pulmonary reperfusion edema, but now that we understand better the procedure, actually it was mostly probably more injuries to the lung by either wire perforation or dissection of the vessels, but it was more than just edema. Actually, it was more like hemorrhagic injuries. The technique has been refined in the last 15 years by being more conservative and a gradual approach with undersizing of the balloons, sequential dilatation of the lobes and segments over multiple sessions, and also use of pressure-guided reperfusion, where they try not to create too much flow distal to the lesion. So mostly gradual inflations helps actually limit the amount of pressure that will perfuse the distal vessel, and so that to avoid this reperfusion edema. And also we use intravascular imaging with ultrasound or OCT, and also we avoid some types of lesions, like tortuous lesions or complete occlusions, who have a higher risk of complications. And this is the Japanese experience. The Japanese have been developing this field because culturally in Japan, people don't want to have surgeries. They don't want to have open heart surgeries. And that's prompted the operators to develop this technique. So they have the largest experience, and they reported that in this paper in 2015. So it consists of 308 patients who underwent BPA from 2004 to 2013. These patients were either non-surgical or patient refused to have surgery, and it was performed at 7 different centers. And you can see that, again, they showed a good improvement of the functioning class. and that is correlated with the reduction of the mean PA from 43 to 22, so quasi-normalization of the pressure, increase of the cardiac index, and most importantly, reduction of the PVR, which is a very important determinant of survival. And this is the European experience. I just listed there the reported, the actually published papers, but in some, we know that there have been more than 2,000 procedures done in Europe, and they led to similar results. It's important to, in order to perform this procedure safely and successfully, important to recognize different subtypes of lesions. So there are 5 subtypes. You can have a ring-like stenosis, which is probably the simplest lesion to treat. Web-like, which is more like a hazy appearance of a vessel, but if you do an intravascular imaging, you will see a web of fibrotic tissue obstructing the lumen, subocclusion, complete occlusion, and very tortuous vessels. And you can have here type A is 100% of success rate and goes by decreasing. I think type D and E are the most difficult and also with the lowest success rate and the highest complications. In my opinion, probably we should not try to tackle these lesions. So talking about complications, they consist in lung injury, lung hemorrhage caused by the wire or balloon, vessel perforation. Sometimes when you cross these lesions, you don't know where your wire is going because you don't have any flow distal to the occlusion. So that is a risk for perforation the distal vessel. You can create vessel dissection, vessel thrombosis, and also create induced reperfusion edema. And also you can have contrast-induced acute kidney injury and radiation injury because these patients need multiple and long procedures. So that's a significant complication that you should keep in mind. Finally, I'm going to just talk about the pharmacological treatment. This is the study that puts riociguat in the map for the CTEPH, published in New England Journal, and about 280 patients were randomized to either placebo or riociguat, and the riociguat increased the 6-minute walk text by 40 meters at follow-up, and also showed a reduction in pulmonary vascular resistance by 226 dyne, and some other parameters such as functional class as well. And we see that the benefit was sustained over 16 weeks follow-up. The other pharmacological treatment can be, of course, lifetime anticoagulation, and we still use off-label prostacyclins, androstenedione receptors antagonists, and phosphodiesterase type 5 inhibitors, because we think also that this is not only an obstructive disease but also microvascular disease. Finally, the most recent guidelines, as shown here, say that if PA survivors present with exercise dyspnea and other symptoms, the CTEPH should be considered, and the patients should be on lifelong anticoagulation if CTEPH is diagnosed. And the first thing to think about when seeing a patient of CTEPH is he operable or not? Because the pulmonary endarterectomy is, at this point of time, the gold standard can be curative in this patient. If they are high-risk surgery or technically non-feasible, then they should be on riociguat. It's a class 1 indication. And finally, BPA, intervention BPA is class 2B because of the still lack of long-term follow-up and data. So this is just schematics showing that for the tailored invasive therapy, if you have a patient, you have to evaluate his surgical risk and also the lesion localization. If the patient is high-risk surgery, then we favor BPA. If the lesions are more distal, meaning the surgeon would have a hard time actually to get to this segmental and subsegmental segment, then probably BPA would be better for this patient. But if the patient has proximal disease and very low risk of surgery, they should definitely be directed to surgical intervention. So which therapy for which patient? As I said, PA is the gold standard and potentially curative. BPA for patients who are inoperable, who had suboptimal PVR reduction post-PEA, or in addition to PEA to tackle distal segmental lesions. And also, some centers say that maybe if the surgical expertise...
Blue, Providence, level 2, Thurlow Street entrance. Code blue, Providence building, level 2, Thurlow Street entrance. Code blue, Providence, level 2, Thurlow Street entrance.
So in some centers where there's no available expertise, surgical expertise for endarterectomy, BPA can be a good alternative for patients. Finally, riociguat is recommended for inoperable patients or patients who had residual pH after surgery, and can be also used as a bridging therapy before an invasive therapy. Conclusion, CTEPH is a treatable and potentially curable form of pulmonary hypertension. Prevalence of CTEPH is probably underestimated. The pulmonary endarterectomy in a center of expertise is the gold standard treatment, and balloon pulmonary angioplasty is a potential alternative to pulmonary endarterectomy. This is the algorithm that is recommended following the 5th World Symposium on pH. So CTEPH, if a patient is diagnosed with CTEPH, he needs to be on lifelong anticoagulation, and then he needs to be assessed for operability by a CTEPH team, analog to heart team, for example. If he's operable, he should have pulmonary endarterectomy. If he's not, then medical second opinion in another experienced center. Otherwise, targeted medical therapy, maybe percutaneous transluminal pulmonary angioplasty, and otherwise refer to lung transplant. And I think this is how it works here in our center. However, for now we don't have a surgical expertise, and we don't have the option of transcatheter angioplasty. However, we were talking, Nathan and me and the rest of the PH team, of maybe starting a program like that. But still, for now, patients need to be transferred either to Ottawa or Toronto. That's it. Any questions?
So that's true. The only centers that are doing PA in the country are... Oh, got it. There you go.
I was going to put the last line in.
It was an excellent talk, Mounir. So that is true. So right now, the only centers that are doing large volumes across the country are Ottawa and Toronto. So we've had to bedline quite sick CTEPH patients to Ontario at great cost. And certainly elective patients have to travel there of their own accord. It's a big, it certainly is a big hurdle. And many people just don't go because of the hurdle that's there. When you're talking about BPA, which is more and more. So that's a bit dated now. That's the 5th World Symposium. The 6th World Symposium was just this February. And this predates a lot of the newer data out of Japan and Europe, looking at pretty decent reductions in PA pressure and improvement in status following BPA. So that's moving further and further up the algorithm, and it's now people are thinking about studies where they're randomizing to BPA versus medical therapy. I believe there is one underway. It's a big need. Often these patients require multiple different sessions of angioplasty. Toronto has been doing it for about a year now, but they're only offering it to people in the Toronto area just because it just isn't feasible for patients out of province. So it is a big area that of deficiency in care for CTEPH. And certainly would be great if we could provide that to patients locally. So I'd be interested to hear about your experience during your training of doing balloon angioplasty.
Yeah, so when I was in London, I was training actually in congenital intervention and structural intervention, but the cath lab we were working in with the professor there, we occasionally had some CTEPH patients sent by it was not per se a organized program, but still we were doing those pulmonary angioplasties for congenital pulmonary stenosis. So for us, it was quite the same equipment and the same principles of treatment. So we did a few cases, and I did not have follow-up of patients because I did not follow them clinically, but it seems that it's something that was very gaining a lot of momentum in Europe, and here, sadly, in Canada, we have one center, and I think that's when I came here, I just realized that all the Western Canada, there is no one doing that, and must be many patients who can actually be treated, and these outcomes are actually good now that the techniques are refined and the pathology is better understood. I think there's no reason why we should not offer that to patients here.
So are there any other questions? Dr. Ramani.
Thank you. I was just wondering if, from the Japanese studies, if you have any data on the mortality as compared to patients that do not go under treatment, because the gold standard shows 10% at 3 years. Do you have a sense of what the mortality is with the BPA?
So yeah, that's one of the Achilles tendon of this procedure is we don't have a long-term follow-up. So there's no published data about 3 years follow-up, for example. I think there were some presentations in conferences about 1 year follow-up, and they seem to be quite the same, but I cannot say that at 3 years it's doing better than, or at least the same than PEA. And keeping in mind also that these patients probably are higher risk because they were also not candidate for surgery. So it's very hard to compare both modalities.
Any other questions or comments? Yes.
I'm going to preface this silly question by a comment on bronchial thermoplasty. So about a decade ago, that came in, and they did smaller and smaller vessels, and they did it better and better. In this case, if you're dilating the vasculature, do you ever think that it will move into primary pulmonary hypertension? Is there any hope at all?
Not sure if so your question is if we do open more vessels, this patient would turn into pulmonary hypertension, or?
No, in CTEPH, there's a limited application. And it's a great application and very exciting. But even more catastrophic disorder is primary pulmonary hypertension and what to do about that. And so if you develop a skilled team of people worldwide who does this step-by-step procedure in CTEPH, is there any way in the future to extrapolate that to other applications in pulmonary hypertension?
Well, I think it's a different disease. Pulmonary hypertension is mostly microvascular disease and with intimal replacement. And this, to my knowledge, I don't think, unless you find targets for obstructive disease, I don't think the approach would be applicable to that type of hypertension.
So yeah, I definitely agree. So this is so idiopathic PH, or is what is now what used to be called primary PH is idiopathic PH, and it's a microangiopathic process involving really, really tiny vessels, like on the order of 100 microns or so. It's pretty, they're small. So that a mechanical solution to that just really isn't feasible, but it's an interesting thought.
Any other questions or comments? So I just have a question about the balloon angioplasty. You mentioned the stenosis and the webs. Do you try to get beyond them and come back? How do you prevent anything from going upstream, or do you?
It's a very good question. Actually, we don't prevent anything going upstream. The only thing that we try to do is to disrupt those fibrotic connections that form the webs, and hopefully actually tack them on the wall, so that to have less obstruction to flow. But certainly there will be, everybody is thinking, how can we also prevent from creating and shedding material going upstream? And certainly this is also a limitation of this procedure. And I think I was actually thinking about this procedure many times, and maybe there are some techniques for distal protection from embolization that we use for coronary intervention that can be applied to this technique, providing that the equipment would be actually suitable. But it's a very interesting thought. Yeah, it's a limitation of this technique, and I'm convinced that this technique is still very new, and the progress in the next years will be tremendous. And probably also thinking about some stenting using bioresorbable material, and all that we learned about the coronary intervention can be potentially applied to these lesions. And I'm actually excited to see how this field will evolve in the next few years.
I have a follow-up question to that. And it's just that my anatomy is poor, but the pulmonary vessels are not as robust as the coronary vessels, right? Mm-hmm. So how do you prevent perforation?
It's a good question, actually. When you read about these operators and what they recommend, usually we will never go up beyond 6 or 8 atmospheres when deploying these balloons, whereas in the coronary tree, for example, we'd go up to 20 to 24 atmospheres for robust lesions. So certainly we're much, much more careful when dealing with the pulmonary vessels.
If there are no more comments or questions, I'd like to thank our speakers. Thank you very much.
Thank you.
I remember your 9-year-old cut his hair. So cute. Oscar, what is his brother like? Oh, they're great. Yeah. He's like, hi, I can locate you right now. Like, easy going. What is that? Oh, that's great. Oh, this one's great. Good so far. So good. 50 likes. 5 years.
And also,
I understand that I'm meeting What's the percent of patients that are useful sitting against
yeah, maybe.
What's the cost of getting the census?
I think you probably that we can talk. There's a fear that we so I keep talking about how we assess people of the tree.
Is there a timeline where the literature says once you're in get done? Yeah.
The longer you keep the patients, you have problems, it's better. You definitely want to give them trial life variation. At that point, the higher the peak are, more likely to work down, but also the higher the mortality.
What is the structure?
You see what the soluble cyclics stimulate. So it works on probably the reason why I feel but we're hoping that's going to change. What you force that there is some evidence that there was a study which showed no improvements in the long, but the useful sense of effect. And people who have cardiology.
When you say you wait 3 months, I'm just going to
So usually they come in, we have a few in the car, and we have a license.
But you don't take, like, how often do you get people? I'm all over the list. Yeah.
Usually it's an option.
I've never met before. I'm the phone. I was actually curious since you guys have a registry.
So we have a clinical database. We have it's been around since 2006.
For me personally, what was of interest is whether there is a potential to collaborate around the introduction of the DOACs in terms of design of some of our evidences. When patients are being discharged from the emergency room, we'll follow up on a DOAC, and I see them at 6 months without going into not having that talk about it.
So our data is going to not quite nearly under that, but now the other, I mean, what do you think? So, what do you think about the use of the wax? I've been using it for more. Haven't used it. I mean, back when I was going on my training, around 2000,
With everyone.
there was, you want to hear about the wax.
Danielle,
People were still
what's she doing?
because of the wax experience. But then there's not a lot to be done.
I'm not. Well, we had no choice.
Yes.
With warfarin or nothing. So, yeah.
I had it there. Used to get some required stuff.
So my concern is not so much when you go to the chronic. It's not so much the chronicity of disease treatment. It's the early on, very heavy phosphorus rates that get treated with DOACs. And I have noticed in very small numbers where people remain symptomatic until I switch to the molecular heparin, and then I bridge them back to, not bridge them, but 30 days of molecular heparin. It seems to have this anti-inflammatory effect. Allows for much rapid response. And then I put them on the DOAC. So I've tended to stay away from the DOACs and I keep them in dose. Even though I've already discharged them, I give them what happened with last year. I have no evidence to have around the say it.
It's an area where we definitely need more evidence.
Yeah. So I, where is there a role for us to be able to have the registry? Is there a way that we can collaborate and we have the numbers to you would see more. Are you seeing a blip in diagnosed supplementary hypertensions
We have to separate that from looking for it more, but so many things.
Very nice to meet you, and thank you for
Likewise.
that.
Thanks for coming.
And great to see you.
Likewise.
Again.
Likewise.
Congratulations on your beautiful family.
Oh, thanks.
So lovely. Happy to hear that.
We're done now.
Yeah. I said that. Yeah, you too. Yeah. Don't be like that.
How many give them? I have three.
Yeah. So nice. The whole file. So you notice that those features in the tube? Any of features? Oh my goodness. I was like, what? Like you could just leave it. It's okay. We'll come around in an hour. No, I'd rather bring it. Dr. Passive check. Yeah. Potentially do it a little bit. I'm just wondering if we're post this like gaps. Oh, right. Get out the door. I was thinking potentially next block. I'm not sure, like right off the but potentially for that far. So maybe I'll just send your It's actually more powerful to go out there.
Your call will be disconnected.